and myself, Dr. Joanne Levin. We also have our esteemed Director of the Northampton Department of Health, Meredith O'Leary, and our staff, Kelly and Amy. This meeting is a continuation of the Board of Health meeting originally held on December 28th, when we did hear 3 hours of public comment. All who raised their hands to speak at that meeting were heard. I will take the liberty to speak on behalf of all of our board members when I say that we are truly interested in the comments and opinions of all those who live, work, or study in Northampton. Your comments are frequently informative, and we often learn new perspectives on the issues which may and should influence our deliberations. However, hate speech is never welcome here. The Department of Health and our board members have also received hundreds of pages of emails, which were just any discussion? All in favor? Laurent?
Yes.
Cynthia?
Yes.
Suzanne?
Yes.
Joanne? Yes. Okay. Our Board of Health meeting is officially open at 5:35 p.m. Okay. Now, Vivian.
Hi,
Thank you.
I'm going to start sharing my screen and hopefully that goes as planned. All right, can you all see my screen with the presentation slide?
Yes, we
Yes.
can.
Perfect. Okay. As you may all know from my frequent updates, I try to update the public weekly on our data, and then I also post it to our website. It's been quite an intense couple of weeks here. So just since January 1st, we've had 23% of our total confirmed cases to date have occurred since January 1st. And that's in keeping with trends that we're seeing, across the nation, across the state. So I don't know that is, surprising, but it's still, alarming. So in the past 14 days since we last met on December 28th, we've had 788 new cases reported to us, 743 confirmed cases, meaning they had PCR tests. This data does not include home tests. Those are not reported to the state. So we know that this is likely an undercount. On average, we are seeing 56 cases per day over the last 2 weeks, and our highest was 108 new positive tests in one day on January 3rd. So our 14-day incidence rate is now up to 200 cases per day per 100,000 people. And the state's reporting our positivity rate here in Northampton is 8.3%. And that is only done out of our molecular tests. It does not include antigen tests, whether they be home test or proctored. In the past 7 days, we've had 511 new cases. So the bulk of our past 2-week data that I just reported on did occur in the past week. Our average in the past week was 73 cases per day, and the 7-day incidence rate is 260 cases per day per 100,000 people. Do you have any questions about this slide?
Would you just tell me the total number of cases since the beginning of the pandemic in Northampton? So it's 23, that would be 23% of,
So confirmed cases is what I report on.
oh, 2,800, okay.
Yeah, I report on our confirmed cases since probable cases do include antibody tests that were done at the beginning of 2020, as well as antigen tests, which are sometimes overruled by negative PCR tests. So I'm only including our PCR confirmed test results in that total confirmed case count.
Okay, thank you.
And that's 2,856 total cases for those of you who are on your phones.
So the population of Northampton is about 28,000, so that's 10%. Assuming it's one individual per case, okay.
Yep, and that assumption is often true. I will say we have had reinfections. I don't have exact data on that. I'd have to really, comb through my reports to really identify reinfections, but I know that the reinfections are being looked at by state epidemiology as well as the CDC. Okay, so hospitalizations, this is kind of a hard graph to read. I understand that, so I'll explain it. I just wanted to show hospitalizations compared with cumulative cases. We've kind of seen hospitalizations mirror case rises previously. I will say we have had hospitalizations rising in the past month since our cases really started to soar upward. But they have not been going up, at the same degree, as they were with mirroring cases in previous surges, which is reassuring. I think we have maybe a 1.4% hospitalization rate in the last month for new cases. But the problem is that we have so many new cases that as a function of that, we're going to see a rise in hospitalizations. Not to mention that our local hospitals do serve more than just Northampton, so that should be considered as well. This data does not include ER visits, which are also a burden on our hospitals. They don't include primary care visits and they don't include urgent care visits. They're just inpatient hospitalizations with COVID-19.
Can I just clarify something that I think is true, but looks funny on these graphs?
Yeah.
On the graph on the left, it looks like hospitalizations are higher than cases, but they're using different y-axis, right? The
Yes.
hospitalization uses the axis on the left, and the cases use the axis on the right. So one is not really higher than the other. You're just looking at the shapes of the graphs. And same is true for the graph on the right. There are different numbers on the left and the right, and we're really focusing on the shapes of the graph and how they track each other, as opposed to which one's higher.
Yes, and I do want to be transparent about that. I don't want to come across as disingenuous in any way. Hospitalizations, that's correct. So hospitalizations are on the left side column. We've had almost a total of 140 hospitalizations. I will say hospitalization data can be underreported too. It relies on some degree on individual reporting for cases from their medical records that could come from us talking directly to infection control, talking directly to patients, or from, I think, teleform reporting directly from the hospital. There is a chance of underreporting with that. But yes, on the y-axis, which is on the left, that's our hospitalizations, and that corresponds with the orange line on that left side. And then with the blue line on the right side.
So I have two questions.
Yes.
First question, is it fair to say, if you look at April 2020, right, on the left graph, you see an orange line with a slope that's far steeper than the gray line, right?
Yeah.
Whereas in contrast, when you go to current times to the right, you see a steeper gray line than an orange one. And the interpretation would be there were more hospitalization per case in last year in April 2020 that there is now.
So there's two factors there. There were certainly more hospitalizations per case. We didn't have as good of outpatient treatments available. So more people ended up being hospitalized. But another major factor to consider is that it was very hard to get testing at that time. You really had to be kind of hospitalized or at a point where you were almost hospitalized or at risk for hospitalization to even get a test. So there was a huge undercount of cases at that time in 2020.
Okay. And then second question, so COVID-19 hospitalization, am I to understand this is someone who comes and says, I have COVID and I feel really bad and I need to be hospitalized? Or is it someone who shows up because, I don't know, they had a heart attack and in the process of checking on them, they will do a COVID test and find out they're positive? Is it both of those cases?
Both could happen. More often, it's going to be somebody who's hospitalized with complications of COVID-19 who I included in this data. So this is data that I, and my team collect from COVID cases. Sometimes if they're in the hospital for something other than COVID, I don't mark them as hospitalized for COVID because that, for my purposes, they're not hospitalized for COVID.
Yeah.
So
I know there's a lot of media attention about that.
Yeah.
And I'll say from my experience at Cooley, we're not seeing we are seeing occasional patients being admitted with COVID rather than because of COVID, but most of our patients are admitted because of COVID.
Yeah.
So the reason I'm asking this is because of the New York governor suggesting that it was half and half.
I don't think we're seeing that, but
Okay.
I haven't looked at that data just from my quick view of our cases. I don't think we're seeing that kind of number.
Okay.
Any
It
other
certainly
questions
can
about this
happen.
slide?
Sorry?
Any other questions about this slide?
Okay,
Go
I'll move
ahead.
on. So
Mhm.
like I said, while it's reassuring that, that slope is not as steep as our rising cases, the problem is that our local hospitals are also serving other communities. And in addition to that, COVID patients tend to have long hospital stays, so they are taking up beds. So with that in mind, I do want to look at Cooley Dickinson's hospital data, and I think Dr. Levin here is going to have some more insight to share with us about what is going on over at Cooley.
Yeah, so you can see these are our different surges at different times, and this is our census of COVID positive patients. They are all in private rooms and they take a lot of time to take care of because people put on their PPE and all that. So the peak in our previous surges was 21 and our peak recently has been 25. And again, the hospital is not functioning as normal. We've cut down a lot on elective procedures and surgeries. And some of the staff from the procedural areas are helping out in the ICU and in other floors. We have a lot of, our beds are totally full and we have people being held at sort of on paper being admitted, but not actually having a bed. And we have an overflow area in our procedural area. So things are not functioning as normal and in their ideal manner, but they're functioning. Any questions about that?
Oh, just this is as of January 2nd, 26, and is it still?
No,
at
that's the peak there, but actually the last number is 1.6. This data is put out like once a week. So.
Oh, okay.
Mhm.
Got it. So but you don't have a sense for what it was 1 week later. Have we increased from 26 to 30, or 26 was really the max, or you don't know?
25 was the maximum that I've heard of. And so we had 25 and then it went down for a few days. And since the 6th of January, I think it's gone back up to 25.
Okay, got it.
So it's
And
not
Joy-
decreasing yet.
Okay.
And Joanne, my understanding is that staff is taking a big hit from COVID and also from the Great Resignation. So do we have a percent of employees that are down at Cooley Dickinson?
No, I don't know that. I know we have had many employees either out because they have COVID or because they're out. We don't keep our employees out with an exposure. But if they have a household exposure, they do need to be tested before they come back because that's a high risk exposure. But I don't know that number.
And they're operating under the 5-day rule too. Is that correct?
That is not correct. Healthcare is different and they're not operating on the 5-day rule.
Okay. Thank you.
You're talking about how long they need to be out with COVID?
Yes.
Yeah, so we have a new return to work policy, which is just new since Omicron and since the CDC rules. And the CDC rules are different in healthcare. They're not the same as the public, but we are in, there are different levels, different rules for how much of a crisis mode you're in. We're in one step up. We're in, I think it's called contingency mode. And the next one up would be crisis mode. So we're not considered there. But the CDC standard for healthcare is, I think, 7 days out. But because we're in contingency mode, staff need to be out 5 days. And what we're doing, because we're part of Mass General Brigham's system, is we're doing what they are doing, which is our system is actually sending our employees an antigen test kit. And they can test somewhere between day 6 and day 10. If they test positive, they have to stay out till 10 days. And so if they test negative, they are allowed to come back between day 6 and day 10. Any other questions about hospital? Thank you. Vivian, do you have any more?
I have Bay State as well. This is from their press releases that they've been releasing on Inpatient Census, and I did want to look at that since they are our level 1 trauma center for the whole Western Mass. As of yesterday, they were reporting 307 inpatients, 34 of whom are in critical care, and that's across their different campuses. Bay State Medical Center in Springfield had 245 inpatients. Bay State Wing had 23. Bay State Franklin had 13. Bay State Noble has 26. And this is, still very relevant to Northampton, as many individuals require hospital level care for, COVID-19 as well as other conditions at Bay State. And you can clearly see if you just look back to December 24th, just the sharp increase in hospitalizations over the last, half a month. Any questions about that slide? We don't have as much, insight into what's going on over at Bay State, at least as far as I know, as we do with Cooley Dickinson, since we don't have a Dr. Levin there.
Can we or Dr. Levin for Cooley Dickinson comment on, out of those cases, the ratio of vaccinated, unvaccinated? Or we don't have that data? That
data is not available in the press release. What I can say more anecdotally, and I emphasize anecdotally from people who are hospitalized with the vaccination, is they oftentimes only had the primary series and have not, had a booster vaccination, and that's been my experience, or they have not had a vaccination at all, or often tragically, there's cases where they had one of the vaccines and they caught COVID right between getting the 2 doses. So what we are seeing really reassuring data with the booster vaccinations in terms of its effect on severity of illness.
I'll agree with Vivian on that. Just from my quick perusal of some patients, it's rare to see patients who have had booster doses being admitted to the hospital.
And that's consistent with what's really being shown in research is waning immunity or really waning immunity from, if you just had the primary series, and that's why, we have the booster vaccine to be up to date now.
Would you comment on the age of people that are hospitalized? I know
Age-
there's a range, but if there's a trend that you can describe.
I mean, age is certainly a risk predictor, as are, if you have underlying health conditions. So there is variability, and I would say there's more variability than in age than there is in the presence of underlying health conditions. And I say that, not taking it lightly, that, people with underlying health conditions are still people, and, they shouldn't be getting sick and getting hospitalized.
I don't have any information about that. I haven't really looked at that.
That is data that we collect when we investigate hospitalizations, as if, they have underlying health conditions. Okay. Oh, I think this is it.
You're done?
Yeah. I had more stuff, but maybe I can share it next week.
Thank you so much, Vivian.
Thank you, Viv.
All right. 1 second. All right. So the only other topic we're going to discuss tonight is continuation, or the beginning of our discussion of vaccine requirement and efficacy of vaccine. And I thought I would open this discussion by talking about the science of SARS-CoV-2 transmission as I understand it, because I think it's important that we're all on the same page. And I want to make sure we're all sort of in agreement with the science. I'd like to clarify that when people talk about vaccine protection and efficacy of vaccines, the words efficacy of vaccines from infection means a positive test is very different from efficacy of vaccines or vaccine protection from severe infection and death. So when we talk about effectiveness or efficacy of vaccines, I think we really need to be very clear what we're talking about. And I'll say from my point of view, we have really a good data on the original strain of COVID, of SARS-CoV-2. We have good data on the Delta strain, and we have very little data, because it is so new, about Omicron. So the history of transmissibility, as I understand it, is that with the original strain of SARS-CoV-2, we learned that our vaccines were extremely effective at preventing severe disease and death. And vaccines significantly decreased shedding and transmission of disease at that time when vaccines were first instituted. So at that time, in my mind, a vaccine requirement for public, this is my opinion at this point, a vaccine requirement for public spaces where people would remove their masks or breathe heavily made sense, because vaccination decreased transmission. Okay, back to the science. In the summer of 2021, we learned we had a new variant, which was Delta. And we learned that protection by our primary series was not as good as it originally had been in prevention of infection and transmission. And actually, the CDC wrote up the experience of disease transmission in Provincetown from that July. And when they looked at the folks who had COVID and compared the ones who had vaccination and the ones who didn't, they had the same viral load, the same amount of virus in their nose. And this was new. This was different from what had happened with the earlier strain. And this was unexpected. And this was all documented in the CDC. Booster doses at that time definitely improved things. And it was shown that during the Delta surge, those who were boosted were 5 times less likely to get and spread COVID, that means a positive test, compared to those who were not vaccinated. And those who were vaccinated were not as infectious for as long a time. Unfortunately, recently in December, while we were still in a Delta surge, along came Omicron, and it has the highest transmission rate of any SARS-CoV-2 we have seen before. It appears to be more resistant to our vaccine-induced immunity. While it is considered relatively less severe compared to other variants, it is still sending record numbers of patients to the hospital with complications of COVID. The surge is only about 1 month old, and so there's a lot that we do not yet know about it. From my own observations, I see that there are a lot of breakthrough cases, and we do not yet have good data to know if vaccination or boosters protect significantly from infection or transmission. But we do know that vaccination, especially with boosting, which is now called being up to date on vaccination, continues to protect from severe disease and death. And we see that in our hospitalizations as well. So I'd like to do a little slideshow. I'm just going to see if I can figure out how to do this. A second. To move some things around.
You see on the bottom of your screen a green tab?
Yeah, it was covered by my, oh, how do I know which one?
You'll have multiple screens up there. Pick the one that your presentation is.
The pictures aren't coming up. Oh, share, does that work?
Minimize your Zoom screen and just open up on your desktop the presentation, and then maybe you'll have a picture of it.
Oh my goodness.
If you want to send the presentation to Laurent, he can share his screen.
Did we lose Joanne?
Oh, yes.
I
Oh.
think she's gone. She must have
Oh.
hit leave meeting by mistake as she's trying to figure it out.
Okay.
So,
I still see her.
oh, you do? But we don't hear her.
Oh, I see a message that says
There
she's.
you go. Now I'm back. I'm sorry. This is not working out well. I'm going to try one more time. I apologize for this, but I couldn't see which screen to open. I'm going to try one more time. Share screen. And the pictures of the screens are not coming up. Why
Joanne,
is
do you
it?
just want to email it to Laurent
Sure.
and then he can share his screen?
Okay. Okay. I will do that. So let me, I'll just finish. So what I wanted to show was the efficacy of vaccines, as our state DPH has shown the data, and also data from the CDC, how vaccines and especially boosters protected against severe disease and death. But admittedly, all this data, and even the most up-to-date data that's on CDC, is from October, which was when we had a Delta surge. And I'll stop there, and Laurent, I'll email that to you. Would anybody else like to make a comment?
I would.
Okay,
Okay. I think some of the things I'm going to say are going to echo what you said, Joanne. As far as the vaccine mandate is concerned, the rationale for this is that limiting space only to those who are fully vaccinated would reduce or eliminate transmission. And then the customers and staff could assume that they're at a lower risk of being infected. And I think a mandate like this would be worth the effort if checking the vaccine status would screen out those who could spread COVID. And unfortunately, the evidence to support this is lacking. As Joanne said, COVID vaccines are very good at reducing the risk for hospitalization and death. But this explosion of breakthrough cases in those fully vaccinated demonstrates what we have known: the vaccines are less effective for reducing transmission, especially of the Omicron variant. And many of the breakthrough cases are asymptomatic or not yet beginning to have symptoms. So a vaccine mandate would screen out uninfected, unvaccinated persons, but it would not screen out asymptomatic infectious persons who are vaccinated. So the intervention wouldn't do what was intended. And responsibility for enforcing this, like the existing mask mandate, would fall to the employees of businesses that continue to be among those who are most severely battered by the pandemic. And the health department, as we all know, does not have the resources to help. Masking indoors is already required, but appropriate masking is confusing and can be uncomfortable, especially while eating, drinking, or exercises. So masks often end up being used incorrectly in those spaces. Based on my experience picking up takeout, the masks come off as soon as the patrons are seated and they stay off. Employees are trying to enforce masking, and I understand how difficult this is. Every day, I have to spend time reminding those in my office about appropriate masking. It's tiresome and it becomes contentious. And I am not depending on tips from my patients for my livelihood, like the restaurant folks are. Everyone is exhausted and quite cranky after 2 years of COVID. And this Omicron surge to me feels particularly offensive. And we all want to do whatever we can to get through this and get back to some sense of normalcy. And mandating vaccine indoors may seem to make common sense. It's something that can be done, and doing something can bring a sense of relief. But will it help? New York City's vaccine mandate for indoor entertainment, recreation, dining, and fitness establishments has been in effect since last August. Yet COVID hospitalizations in New York are up 234% in the past 2 weeks. And like here, those hospitalizations are largely driven by unvaccinated patients. To summarize my perspective, I think requiring vaccinations to enter these specific establishments that we're talking about is unlikely to have the impact on reducing transmission that we would hope. It would be a further burden on the battered sector of our economic base that's already struggling with mask regulations. And the mandate is likely to give a false sense of security to those who are vaccinated if they don't realize that a sizable number of other vaccinated patrons can in fact be infected. And with that false sense of assurance, other prevention measures start to slip. So what can we do? We can focus on what we know works. We should continue to encourage vaccinations. They're very effective. If you're vaccinating, you're helping the healthcare system, the terribly overburdened healthcare system. And I would hope that some businesses would choose to require vaccines to enter their premises as an added safety measure. And we should give these businesses our support for their extra efforts. We should patronize them. If you support vaccine mandates, patronize those restaurants that are implementing them. And the mask should be kept on except when you're actually eating or drinking. You pull your mask down, take a bite or sip, then pull your mask up to chew. It's a lot, but that's what's required. And I think we should move forward assuming that anyone we encounter in any indoor space is potentially infectious, even those who are fully vaccinated and asymptomatic. And we can continue our appropriate prevention strategies of masking, distancing, and disinfecting in every indoor space, not just bars, restaurants, and fitness and entertainment spaces. I had hoped a vaccine mandate would help, but at this point, I don't think the evidence is there to support it.
Thank you. Would anyone else care to comment?
I will, but I can show you slides first if you'd like.
Oh, sure. Thank you.
All right, let me share my screen.
Thank you.
Can you see?
Can you make it a little bigger?
Yep. How's that?
Great. So this is data from our state health department comparing cases for unvaccinated, vaccinated, and boosted. Again, this is only through December 4th, and that was before Omicron was present. But it certainly shows that the rate in unvaccinated, way on the left in the light blue, was significantly higher than those for the vaccinated in the dark blue in the middle, and those who were boosted way down on the right in the yellow. So vaccination during Delta did make a difference in case counts as well as, well, we'll see, hospitalizations. Next slide, please. This again is data from our state comparing COVID rates in unvaccinated, what used to be called fully vaccinated, and vaccinated with boosted in the yellow. Again, this is in the Delta era, that unvaccinated folks were 5 times more likely to get COVID and 31 times more likely than boosted folks to get COVID. Next slide, please. And the state is keeping track of what we call breakthrough infections, positive tests in people who have been vaccinated. The first 2 columns are counts, and the last column is the percentage of all fully vaccinated. And I think when people talk about how many people in the hospital with COVID are vaccinated, the number looks high, right? Maybe half or whatever of the patients who are in the hospital have vaccine, and that makes you say, well, that vaccine doesn't make a difference. But that's a misleading statistic. And what you really want to look at is the percent of fully vaccinated individuals who either get disease or are hospitalized over the total number of vaccinated individuals. And the state has that number, at least for its residents. So you hear the percent of all fully vaccinated individuals who got COVID. I think this is cumulative. Is 5.1%. I think this is since vaccination began. So it's about a year's worth of data. And hospitalizations among fully vaccinated individuals is low at 0.09%. And death among cases of fully vaccinated individuals is quite low at 0.02%. Next slide, please. This is CDC data that looks at cases again by vaccination status and booster. And this is the latest data that they are showing on their website. And again, it is from the Delta time. But again, this is cases. Unvaccinated people had 10 times the risk of testing positive and 20 times the risk of dying from COVID. Next slide. This graph shows the various studies that were done showing the effectiveness of vaccine against Delta variant to prevent hospitalizations. And although they're not perfect, they're really very good. And this is even in the Delta era. Next slide. And this is the same data from the CDC, but this time is the graph of deaths. And you can see, I'm not sure why all the lines were going down at the end of October. I thought cases were going up, but anyway, unvaccinated is much higher than vaccinated as far as the risk of death. And that's all I have. Thank you so much, Lauren.
So, but a quick question is really because the data stops in November, it's a reflection of the pass through Delta, as you've pointed out. And we're really looking at something very new. So we can only make some inference, but we don't have we don't exactly know what those trends are until perhaps the whole thing is over and the number of cases starts to drop and we enter a calmer period. My question I have perhaps is, any word of another variant profiling in the horizon? And I'll stop sharing.
I'm not aware of what they call variant of concern right now, but certainly this Omicron variant has woken us all up to the possibility of ongoing new variants. I think it's interesting that new variants that take hold, the reason they take hold and go through a population is because they're more transmissible. So Delta was more transmissible than the original version. Omicron is more transmissible than Delta. So for another variant to take hold, it would need to be more transmissible. And I have to say, I think it just happens, we just happen to be lucky in a way that this variant is more transmissible, but seems to be less virulent, but it didn't have to be that way. And the next one could be more transmissible and more virulent, I'm sorry to say. And that's the idea of that is so incredibly depressing. But I don't think we know. Is this the end? Everybody, most people are going to get either infected or exposed or vaccinated. And is this the way we get to sort of, it's not herd immunity, but somewhere where everyone is protected enough that it stops surging in this manner? And we don't really know.
I'd like to know, is the current, setting aside going out of COVID and taking the flu, is the current flu, the variant of the flu that we have nowadays, a descendant of the 1918 flu? And can we use the same analogy that it was initially very virulent and progressively went down, or is the analogy totally false?
There are lots of different strains of flu, and each year different strains circulate. And the only reason that we get a little bit of a heads up about what to include in our vaccines each year, the vaccines change each year because different strains are circulating in the Southern Hemisphere. So we watch and see what flu circulated there, and then we hurry up and try to get our vaccines together to take our best guess of what strains are going to circulate here. And we have had outbreaks, of newer H1N1 caused a big outbreak when it came, and I don't think that has anything to do with, the 1918 flu. Our problem is our flu vaccines are not anywhere near as effective as our COVID vaccines. And I think they're working on using this technology, the mRNA technology for flu vaccine, to make them more effective. But our flu vaccines are lacking, but they're best we have right now.
There are a couple reasons for that. One is that they have to choose the strains that are going in the vaccine so far in advance, because until now, flu vaccines have been manufactured in eggs, an ancient technology that has not evolved in 60 years. And the reason it hadn't evolved is that manufacturers said, we don't have the resources to invest in a new platform. There's no money in it for us. And the vaccine legal scenario is so difficult for the manufacturers to negotiate that they just use the old technology. And so they choose it 6 months in advance based on variants elsewhere. And by the time it gets to us, it's mutated many times. And so the vaccines that we're using have a variable level of effectiveness against the particular strain when it reaches us.
And even actually when there's a good, we call a mismatch, or there's a match, even when there's a match, those vaccines are not as effective as we would like them to be.
Right.
Any other, yeah, go ahead, Lauren.
No, I'm sorry. I just one more question is, could we see a future where there's some sort of a combo flu COVID that we have to get each year? I mean, if we want to in some way.
Yes, I've seen discussion of that.
I think Moderna is already working on that.
There's also work on a COVID vaccine that would target all the strains and not rely so much on the spike protein that mutates a lot. So there's work on that as well. But, you know, vaccines are really difficult. I'm a doctor, I take care of AIDS patients. There's still no AIDS vaccine. And this is, you know, 30 years, 50 years later. So vaccines are really difficult. Cynthia?
Yeah, thank you. Just jumping off from some of thank you, Suzanne's comments. The cities of New York, Boston, San Francisco, most recently Brookline, have decided to do a vaccine mandate. And so I'm making an assumption that they thought that this would make a difference. And since we started this discussion on December 28th, which would have been given us pretty good lead time to do something like this to make a difference, I have to ask the question, will it make a difference? Because so much of our data and the statistics that we've been seeing tonight is that we know what'll make the difference. It's vaccines. Boosted vaccines will make a difference. We know that.
Well, it depends what you're talking about. It will make a difference in hospitalizations and deaths, I believe.
Yes, yes.
Will it make a difference in transmission?
Transmission
is
yeah.
What's the question that we don't have the information for, I think.
And even though I guess today Boston tested its wastewater and they found out that they had significant decrease in COVID in the wastewater, does this tell us that it is waning? We don't know. I mean, I just have to keep going back to the question, what difference will it make? And will it make a difference?
We don't know, and it's very difficult to tease that out. I mean, what proportion of the population at this point in time is going to restaurants and bars and fitness centers? It's certainly not the majority. So if you're imposing these mandates on a small sector like that, what's the overall impact in the population? I don't know how they would measure that.
Yeah.
You look at New York, Boston is recent. I think Brookline is recent. I don't have any familiarity with the San Francisco data, but when you look at the New York data, it mirrors the situation everywhere else. And they've had this mandate in place since August. So just eyeballing it, to me, it doesn't look like it's having a significant effect. And it's quite a burden to place on the establishments.
And
I have to
additionally,
say-
we don't,
Go
oh,
ahead.
sorry, Dr. Levin.
Go ahead.
We don't have the data like we did a year ago when we were doing the contact tracing, being able to identify where the transmission was happening. Vivian can speak to this way better than I can, but there is no data showing that the transmission is happening in the bars or the restaurants. So before, we always make our policies that are data-driven, evidence-based, and that kind of is what moves our needle.
Yeah.
And I would hate for us to make a policy that would have such a huge negative unintended consequence without this data point, very important data point. We see a lot of our transmission happening within households and, between friends and families and gatherings. So I think that's really, really important. And, just from the small data sets that I see, the breakthrough cases are proving that the vaccine is not stopping transmission. The vaccine is working in the sense, as Dr. Levin said, to reduce infection and severe illness, but it's not reducing transmission. I think those are two important points that we need to think about when we pass a policy.
And I'll have to say, I've done a lot of investigation in the last week or two. I've spoken with a deputy at the Boston Public Health Commission, sort of inquiring about their train of thought in doing their mandate. And you have to realize, even though their mandate went into effect in December, they've been probably working on this for months, right? When we were in the middle of a Delta surge. And so they said that they chose the restaurants, bars, and gyms and venues based on places that were high transmission, but were not essential services. New York, when they put theirs in place, included grocery stores, and they just want to do it everywhere. So to me, I haven't really gotten a good answer back from anyone. Like, does this make sense in the era of Omicron? And I've not heard back any answer on that. I mean, we really don't have the data. I've also been in touch with the assistant commissioner of the Mass DPH and asking about data on Omicron, and I don't think I've seen any data from them. They are continuing to push data, as I showed you, on the efficacy of vaccine, and particularly on boosters for severe disease and death, and for hospitalization, but I have not seen data on reducing transmission and cases, and disease.
As was predicted, this rise occurred after the holidays. Everyone said the holidays are going to be very important and like right on time, Omicron explodes. So that reinforces what Meredith was saying. It's close contacts, friends, family, kids bringing it home from school. Not restaurants, bars, and venues.
Yeah, I think unfortunately we had the perfect storm of having Omicron descend upon us right before the holidays, and it's wreaking havoc. Yeah. Any other comments? So this was a discussion item. I just want to point out this was a discussion item. There is no motion on the table unless someone wanted to make a motion. And if we feel like we've discussed it enough, we need not go further. Sort of up to you.
I wanted to add a few comments, but I don't know if Cynthia, did you have further comments? Because I don't know if you had wrapped up what you had to say.
I do have a couple comments, but go ahead, Lauren.
So there were two topics I wanted to discuss. And beyond what you say, which I completely agree with what was said previously, but there are two things I wanted to discuss. One is a feedback on the comments that we received to tell you what I thought, and perhaps you can share your experience, but also so that the public knows. And second, I took the initiative to talk to the folks at the Roost and at the Dirty Truth, and I just wanted to relay their experience.
Great, thank you.
So Cynthia, I can go ahead, or otherwise, if you had something else, it's up to you.
I'll wait till after you, Lauren. That's
okay. Cool. Perfect. So on the comments, I can tell you I've read through all of the comments except the comments that I received today, the 7 pages that we got today, which I didn't read. First, speaking of the public comment that we got on the first portion of this meeting, there were 77 comments as far as I can tell based on my count. As you remember, I think there were all of them but one, the first one, that were relating to this mandate. And by and large, it was overwhelmingly against the idea of a vaccine mandate. It was very passionate, as you recall. And I read through approximately the 300 pages of comments, and as far as I can tell, we had comments from business owners, some of business that I know and have patronized in the past, a number of business employees, some residents and visitors to Northampton, and some comments, I would say, I'm not even sure that they've ever been to Northampton before, just based on the pattern of comments. At the onset, towards the end of December, it seemed that a lot of people were generally against the idea of a mandate, but still I started to see, as time went on, a lot more comments of people in favor of such a mandate. Many of the arguments were the same. I'm going to quote my favorite comment, which was a comment that was against. It was a two-liner, and it was, "Vaccine mandate won't work. You should all resign in disgrace." So that went fast. That made me laugh, even though it was not very pleasant. But some comments were far longer, more elaborate. What I saw, obviously a lot of threats of boycott. If you pass a mandate, I will no longer patronize or do business in your cities. But there were also a lot of folks, and I want to relay that. Many comments that I've read were people who said, I'm not going to a restaurant. I haven't gone to a restaurant since 2020 because people do not have a mandate, a requirement for a mandate. So I think there is a large proportion of the population that wants that. And I am not suggesting that we mandate a vaccine, but I want businesses to think about an opportunity, and perhaps we can give at the city level an incentive to do that, whether it's a financial incentive or something else. But I think there are a number of businesses that would greatly benefit from imposing a mandate. I'm not saying all business can do it, but I think a few can do it. Which takes me to my next topic, which is the experience of the Roost and the dirty truth. I went to the Roost. The way the Roost operates is you walk to the counter, you order your food, and if you want to have your food to stay in, you have to show proof of vaccination. Otherwise, you have to go to take it. You have to have your food as takeout. And I talked to the manager last Saturday, and it was a decision by the owner with their staff. They felt that it was a good decision, a good public health decision. They did not consider business decision. They just thought it's the right thing to do. And they reported no incidents whatsoever. People were, based on the account of this manager, people were cooperative and understanding when they didn't have the proof. I also talked to Kyle at the Dirty Truth, and he relayed exactly the same thing, which is people were generally cooperative. He did not have any incident where things got out of control. He also indicated that they have the benefit, the way they are set up, as you know, there's only one entrance. So again, it's not a one size fits all. But they indicate they have a little advantages. There's always one person that is near the entrance, whether it's the person checking IDs on Saturday nights when it's busier, or a person towards the front, the host. So they have an added advantage that they don't need extra staff to do that check. The only thing that Cal mentioned was there was a bit of a backlash on social media, but that was just that, social media, not in person, no angry mob taking over the Dirty Truth to protest. So I think, business owners should take that into consideration, consider that they can tap into a large segment of the population that needs that reassurance, that need that extra precaution before they are willing to go out and patronize these businesses. So I think that's an important thing. I don't think I have anything else to add that I can remember, but if I do, I will say it later.
Thank you. Cynthia?
Yeah, thank you, Laurent, for that investigative anthropological report. That was great. And you reminded me of the fact that our initiative at the Senior Center, which is a vaccine mandate, came from the ground up. I mean, it really was through public comment. It was through a bunch of folks that were members there that felt this would be a better senior center if we could do this, and we listened to them. So I think that that line of thinking is great. The one thing I just wanted to bring up, I know we don't know, we never know what's going to happen the next day, but Joanne, when you were talking about hospital goes into contingency, then crisis, and there's these different metrics that make that happen. And if we somehow, after we're out of this, can get to understand what metrics would flip what switch, it allows the community to not be so surprised. If we make a policy change that may be for a week or 2 weeks, particularly if we gave the emergency powers to the health agent. So it's just something for us to think about. Unfortunately, now with Omicron, we just don't have the data fast enough to make those future policies, let's say. So then I think that's.
I don't know. Thank you, Cynthia. I don't know what the criteria are, and it's not clear to me there are really set criteria.
Yeah.
When the hospital is feeling stressed and needs to rearrange how they do things, but I can investigate that if you'd like.
Yeah.
You have something
But
else?
I'm thinking about it as a community. What are those criteria? Yeah. So, thank you. No, that's it.
The extra thing that I had has come. I suddenly remember it again. And go ahead. So one thing that Kyle mentioned, Kyle at the Dirty Truth, was, they came up with a protocol using sort of essentially talking to folks in New York, see how things were going and see what they could do to develop their own protocol. They wish in some way that there was some guidance from us, from the health department, on how to do this and how to approach this. And I also heard that comment from another business in town that essentially said, we are in favor. We wish you could essentially take that upon yourself to put a mandate, because you get to have the flack and we don't, as opposed to us doing it and we don't really know how to do it. And we wish you could tell us how to get this done, how to enforce a mandate. And I feel for those businesses. I wish we could provide guidelines, but it's a little bit of it's tricky because no business is the same. Starting with if you have 2 entrances versus 1, if you generally have food to go, or if you, like at the Dirty Truth, you tend to stay, and so on and so forth. I think, the Roost is a great model because it seems to be feasible for this type of establishments, but that would not work elsewhere if you say in a pub and you want to have a beer to stay, right? So all of this to say, and our experience at the Senior Center was, we're not going to necessarily tell everything on how to do things at the Senior Center to check on vaccines because, well, we don't know exactly where the doors are. We don't know where it's a good location to check. So we can provide some guidelines, but we're also limited by, the fact that we don't know the premises very well. We can only remain very, general in our recommendations. So that's the only thing.
I think that's a really good point. And I think at a future meeting, we might talk about what kind of guidelines we'd like to provide to our businesses to be helpful to them. If they want to do this, there's a number of things that I think would be good things for the public, right? For public health, we know there's like 5 things that we think are good. And masking, vaccinations, social distancing. Ventilation is a big one of mine for indoor spaces. I think we haven't paid enough attention to ventilation, and I'm not an expert, but I would like to talk about whether we can get a consultant using our ARPA money and help businesses improve their ventilation. So I think there's a lot we can do on the voluntary side for businesses and for guidance. I also, interestingly, I spoke with Provincetown, Director of Health, and they have a system where if a business wants to mandate vaccination for their employees, or say that only vaccinated people can come in, the Board of Health supports them by supporting them with a sign that has the shield of the Department of Health, but it doesn't exactly say that the Board of Health mandates it, but it's sort of fuzzy language, but it definitely supports them with sort of blaming public health, but yet it's a voluntary thing that the business is doing. So I think we can look in more detail at things like that, where we can be helpful and supportive of our local businesses to do the right thing that we think are good public health maneuvers without a mandate.
At this point, there's no way for those who would prefer a vaccine mandate to get into the premises. There's no way for them to know other than word of mouth. And I think signage could be used as a marketing tool to a portion of the population that I don't know anyone. I mean, it's just my N of one. I don't know anyone who's gone to a restaurant in 2 years. People are just staying home or doing takeout.
Well, Suzanne, we're in a particular demographic, shall we say?
I understand that. But what I'm saying I believe there's a sizable proportion of people who have not been patronizing restaurants, bars, venues, fitness centers because of this fear. And if there was a way to know from the door that this is true, or this may be a little tricky, but the Board of Health could have a list of the establishments that are requiring mandates, just as a piece of public information. I don't think that's showing any particular favoritism to one business versus another, but we can list which ones are enforcing certain public health measures. And if that were on our website, that would be a way for people to find out.
So shall we put this on our agenda, guidance, public health guidance for businesses, and we can sort of flesh that out a little more next time?
Yes, I think that would be great, and perhaps researching a little bit what has been done in other cities, obviously, would make sense.
So on this topic of vaccine requirements, does anybody have anything else they would like to say? And I'm sorry, I see someone from the public raise their hands. I'm sorry, we're not having public comment. This is a Board of Health business meeting, but at our next meeting, there will be the opportunity for public comment. Anybody, other board members? Yeah, Cynthia.
Just timing, and we don't have another scheduled meeting for a month, so I'm just wondering what the thinking is around us. Anything can happen, as you know, with the virus any day, so I'm just wondering when we will come to some type of conclusion.
Well, our regular scheduled meeting is on the 20th. It's always the third Thursday of each month. So
Okay.
the board members are available next Thursday, same time, same back channel. I say we do it then.
Is everyone okay with that? Lauren?
Yes.
Cynthia?
Yes.
Suzanne?
Yes.
Okay. Meredith,
I'm available.
you're on?
I'm on.
Okay, so our next scheduled meeting will be next Thursday, the 20th of January at 5:30 p.m. and there will be a public comment session. So we'll create an agenda. I think one of our agenda items will be about the rules for public comment, but we will not get to that agenda item until after public comment. And we'll get some more guidance from our attorneys about how to do that and from the mayor. We'll also bring up guidance for businesses. I think we also had on our previous agendas, we usually review the mandates that we have in place. The senior center, I think we dealt with last time, but our mask mandate, we always review. If we're still in this surge next week, which I suspect we are, we could further discuss whether there's any short-term or immediate interventions that we can take. So any other comments?
Dr. Levin, I just want to say first how proud I am of my board tonight. I mean, this was so super informative. We stuck to the agenda item. We talked about the science or lack thereof, and I just am honored to be, your support staff for all of you. So thank you very much. I also at this time would like to ask each and every one of you to just give your background and what you do. I think it's very important knowing what you do in a professional role, to how you came to these, to come to your discussion, your presentation tonight, that, I think that plays a big part, and our general public doesn't know what any of you do in your professional capacity. So if you wouldn't mind, just really quickly.
Are you board members willing to do that?
Sure.
Suzanne?
I'm a physician. My previous life was in infectious diseases and public health, and I spent 22 years at CDC. I've done a number of things since then, and I'm currently the medical director of an addiction treatment center in Greenfield.
Thank you. Cynthia?
Yes, I'm retired faculty at UMass Amherst, but I still teach there online, and my discipline, my doctorate's in communication, my specialty is in health communication. Prior to that, I worked in hospital administration at Bay State Health. And prior to that, I served as an officer in the United States Navy.
Thank you. Lauren?
I am an environmental engineer by training. I work for a consulting company. I primarily work on groundwater pollution issues, including all sorts of chemicals. You may have thought about forever chemicals. That's one of them. And I specialize into chemical exposure in residential and commercial properties from the off-gassing of those chemicals in a process of involuntary exposure. It's not unlike radon intrusion, for those who know it, except it's by man-made chemicals. So I spend a lot of time doing risk assessments and looking at data.
Thank you. I'm Dr. Joanne Levin. I'm an infectious disease consultant at Cooley Dickinson. I am the medical director of infection prevention, which also in some hospitals is called infection control at Cooley Dickinson. I have been there for about 33 years. I'm thinking of retiring soon. I started my career with the AIDS epidemic, and that's what I've done most of my career, is taking care of patients with HIV and AIDS, and seem to be ending my career with another epidemic. So thank you, Meredith. Do you want to talk about your background?
Certainly. So, well, gosh, where do I start? I'm a marine biologist by academia standards, but I've been in public health now close to 18 or 19 years. And I've served in a variety of different roles in public health. And about 10 years ago, I landed my dream job for the city of Northampton as the health director.
We love that that was your dream job, and we hope you stay.
And I plan to retire from here just a lot sooner than I originally thought.
May I ask a point of clarification? If we are done with the discussion about a vaccine mandate, does that mean it will not be on future agendas for us?
No.
We- What does that mean?
So I asked Attorney Seawald that exact question, just in case, we have to discuss this because a new variant evolves in the future or something else comes up. And he said, absolutely, we can put it on the agenda again. Whether someone made a motion tonight and it didn't pass, or we didn't make a motion. Either way, we could still put it on a future agenda.
But at this point in time, with the end of discussion, this is no longer an action item for us to be discussing at this time, unless we bring it up at a future time.
Exactly.
Any other comments or discussion? Hearing none. Thank you, Meredith. Thank you, Vivian. Thank you, board members. Would someone like to make a motion?
Move to
Move.
adjourn.
Second,
Any other comments? Hearing none, we'll put it to a vote. Suzanne,
Yes.
Cynthia,
yes.
Laurent,
Yes.
Joanne. Yes. Thank you all. And we will be back next Thursday at 5:30 p.m. on Zoom. Thank you all.
Thank you,
Thank
Joanne.
you, everyone.
Good night.
Night.